99.3 Nigeria Info, and you are listening to the Morning Crossfire, your number one news, talk, and sports station. It's Monday morning, it's the 23rd of September 2019, and today we're looking at the World Patient Safety Day, which was last week, the inaugural one. So we're looking at medical facilities and patient safety. Medical facilities and patient safety. We'll be discussing this for the next 1 hour. The first ever World Patient Safety Day was inaugurated on September 17 by the WHO to raise awareness on patient safety and to urge people to show their commitment to making healthcare safer. The WHO presented some statistics to commemorate the day. 134 million adverse events occur each year due to unsafe care in hospitals in low and middle income countries, contributing to 2.6 million deaths annually. 15% of hospital expenses can be attributed to treating patient safety failures in Organization of Economic Cooperation and Development countries. These are countries considered as developed with a high income economy. 4 out of 10 patients are harmed in the primary and ambulatory services. Up to 80% of harm in these settings could have been avoided. Medication errors also cost an estimated $42 billion annually. This is forming a conversation for the next 1 hour. You're welcome to the show. I'm Wemimo Adewuni.
And I am Sheriff Quadry. Thank you so much for joining us. We are live on Facebook, YouTube. You can also follow the conversation on Twitter. WhatsApp portal is also very, very available on YouTube and Facebook. We are at Nigeria Info 99.3. Feel free to follow us on Facebook and, of course, subscribe to our YouTube channels in order for you to be able to watch us live and see our guests in the studio. On WhatsApp, you can follow us at Nigeria Info FM. And on WhatsApp, our number is 0809 597 5805. That is 0809 597 5805. Dr. T. Mabadu, a medical practitioner and public commentator, joins us right now in the studio. Dr. T, welcome to the program.
Thank you.
It's good to have you here.
Good morning.
Rotimi Sankore is also here in the studio. Rotimi, good morning to you.
Thank you.
And joining us on the line, I think we'll try and reconnect with her. She is the national chairman, National Association of Nigerian Nurses and Midwife. She's also a midwife as well, Nasmadona Wichendu. She joins us all the way from Port Harcourt. She will be joining any moment now. The conversation promises to be interesting. Please drop your comments and observations and your contributions, as a matter of fact, on all of those platforms. Nurse Wichendu joins us now. Good morning, ma'am.
Good morning.
It's good to have you on the line.
Thank you very much.
Welcome to the show. This affects you if you use the hospitals or if you fall sick at all. And if you're a human being, you do fall ill and you need to use a hospital. So this is all about you today. Now, we know that medical services in Nigeria is not exactly applaudable right now. But let's look at how we can move this forward. And I'll start with you, Dr. Tui. Already, we don't have enough people captured in our medical services. Many people don't go to the hospitals because, in fact, some people are still scared of vaccines because they're afraid of what might happen, side effects. I had someone telling me so strongly last week why she doesn't take medication and she makes sure her kids don't take medication because of what she calls side effects. And so they would rather drink herbs, which they believe is more organic and natural, and they believe it works for them. So so we've not captured enough people in our medical services. We're talking about World Patient Safety Day, but let's even talk about the people who are not coming to the hospital and the importance of healthcare.
Thank you. The challenge of patient safety is real, and we have to address it because one of the contributory factors to non-attendance of hospital or non-utilization of expensive medical facilities built from the primary health center to the tertiary is this perception that we're likely going to get harmed in the process of seeking medical care. Of course, when we're talking about patient safety, we're talking about absence of preventable harm, and reduction of risk associated with healthcare. So that is exactly, you gave the statistic, quite scary,
Yes.
As much as 42 billion, 2.6 million deaths, and about 134 million people involved.
Right.
And then most mostly in the low and
Income
middle,
earning.
low income
Yeah.
earning countries. Of course, that means that Nigeria is also included in this setting. The foundation of patient safety is in the Hippocratic Oath, because the first principle is that, primum non nocere. First, do no harm. That's the first principle.
First, do no harm.
That is the first principle. And then this has to flow, from a lot of things. If you are not going to do any harm, of course, the patient knowledge of that healthcare and health process is very key. And then your own interaction with those patients are also very important. The structure of the hospital, how it is structured, arranged, the process in the hospital are very important to patient care. Let's give an example. If you have to go to, in a setting where I had practiced with the state government for quite a long time,
Right.
You bring your child to the St. Martin's Street Children's Hospital or Children's Hospital, and then the mother who does not understand much, maybe that's the first baby, and you have to keep, in attempt to secure intravenous line, a lot of things, you are doing, and the mother doesn't understand. To the mother, since she doesn't understand, she would think you are doing some harm. But all you need to do is pair of us sit her down. This is the process we are doing. We may do this. We're not harming your child. Understand and follow us. So we've moved from that Hippocratic Code to what we call patient-centered care. Whereby the patient's value, the patient's preferences, the patient's thinking has to be involved. In fact,
That sounds like luxury, thinking about
no, it's not, because again,
because I really don't see that happening in general hospitals. Like doctors would come to you, take their time, explain to you what they want to do, and ask you what your preferences are. That sounds really luxurious.
Let me tell you why you'll get there. People are getting aware more and more, and then everybody is maybe looking for some good money. If you're a doctor, you don't have insurance, you're putting yourself at risk. Somebody will come and say, because you treated him this way, because this nurse treated her this way,
Right.
He or she is experiencing this condition and it's now suing you. So it is even in the interest of the medical practitioners or the healthcare workers to assure this patient's safety, to embrace the patient's safety as a tactic to help them stay at work and be free from litigation. So now, I want to give it, because this could make sense with you practical example. For instance, a Jehovah's Witness brings his child to you and says, listen, my own value is that I don't want to take blood. And that's my belief, that's my preference, that's my value, that's what I believe in strongly.
Right.
Now, it will be very foolhardy for you to insist that the blood must be taken.
Except it's a child involved.
No, even as a child, it's going to be very tough for you to, because, there are consequences, because anything in this life, including the natural thing you're talking about, including the organic thing in this life, have side effects.
However, if it's a child involved, you have to think about the child's life first. Because of the Child's Rights Act.
The consent must be sought, right?
The authority,
No.
there's a consent.
So there was a court case that lapsed for years. If you followed it on this same issue, there was a what are they called? These people who don't like to take blood. Jehovah's Witnesses, who then took this doctor to court. The case was just resolved either earlier this year or late last year. That then said the doctor did right by giving blood to the child, because the child's health is primary. When it comes to a matter of life and death, you need to save the child's life first. So that sets a precedence for it.
Again, yeah, this thing is not about legalese. It's because, again, you can put legal to some issues, but again, the reality is that in subsequent visitation, you probably see those people averse to getting to hospital and getting your treatment.
Right.
And then they will tell you that in other countries they've been practicing that thing and they have these options available. So again, you must get to a point where you must make those options clear to them.
Yes.
Look at their values, look at their preferences, and look at what they hold, what is their need in taking decision.
Not switch and do very quickly. Let me come to you. Thank you for joining us from Port Harcourt. So there has been, if you go around and ask people when they visit public health facilities like general hospitals, that one of the things they will tell you is the shabby treatment they get. especially from nurses. How far do you think this number one, is this treatment really true? From someone who is practicing in the public sector. And secondly, how far-reaching do you think this kind of treatment can go towards affecting patients' safety?
Thank you so very much. The truth of the matter is that in our country, in Nigeria, we are impatient. Majority of Nigerians are impatient, and especially when it has to do with accessing care in the medical facilities. When you go to public hospitals, it's totally different from the private hospitals.
Right.
Because your movements are limited. Most of our hospitals are not automated. We are not ICT based. So you find yourself moving from one point of care to the other. And by the time the patient gets to where the nurses are, the nurses station, they are already worked up. You remember when somebody is sick, according to the WHO definition of health, it's a state of complete, when you're well, complete, state of complete, you're well mentally, socially, and not just the mere absence of diseases or infirmities. You might have a disease, you may have a condition that may have brought you to the hospital, but you're psychologically imbalanced because you're sick. You need that care, you need that attention. And they are telling you move from the records department to the pay point before you get to the nursing station, and you're already tense. And the nurse herself there might not be as you expect her to be, because she's a totally different person from you. We are unique individuals. Yes, we are trained to give care to the patient. We are trained to alleviate their pain, their suffering, and all that. But that does not make the nurse a cheaper human. Granted, occasionally you see a nurse who does not get it right. For a patient to have left his or her home, you're supposed to welcome that person and give the person the care that the person expects.
Again, I'm laughing here. And again, that sounds luxurious. I mean, nurses in most government hospitals are the most feared. I mean, people literally shiver at the presence of nurses and matrons. I mean, they look like the lords of the hospitals, and they command go there. Many of them are very mean. In fact, I had to ask a nurse, is it that they teach you guys how to be mean at your nursing schools? Because many of them are pretty mean. So you're saying that you should welcome patients when they come in, that sounds pretty luxurious.
I am telling you what I do as a professional.
Amazing.
There are persons who are called into the profession, who it is in their DNA to render care. There are persons who, irrespective of the training they have received in the institution, do not get it right because they came into the profession because of the ready availability of job on graduation.
And that means there are no standards at the hospitals, no standard for behavior.
No,
so each nurse can behave depending on their mood.
No. There are standards. There are policies in the facilities. The onus now lies on the management of that facility to carry out what their policies say on erring persons. If you know you are there because of the patient, and without the patient you are out of job, then you have to be of your best behavior. And if for any reason one errs and the person is made to face the consequences, I am sure others will learn from it.
Mrs. Wichendu, you said something earlier about the so much pressure being put on the nurses. Number one, they are not superhuman. They attend to tens of people on a daily basis, and this might, in one way or the other, impair their judgment in their relationship with patients. But my question is, are you aware of any provision for nurses, maybe on a daily basis, maybe weekly or monthly, to see a psychologist, a resident psychologist at the hospitals, just to relieve them of this enormous pressure that they're faced with?
In Nigeria, it's a no-no. There
Sadly.
are things that happen elsewhere in the developed world that we are not opportune to have in our country. You and I know that even somebody who has been diagnosed to have a psychological issue finds it difficult to go and access assistance from a clinical psychologist, because to him or her, you are terming him or her a mental case. which shouldn't be. Ordinarily in the developed world, you see people walking to see the psychologist. They lose sleep, they go and assess care. They want to know why they are not sleeping well. If they are anxious or something, they seek help. But if any person sees me now, even though I'm a health personnel, walk into the psychologist's office, the first thing they will say is, Mrs. Uchendo has a mental case. Because of our orientation, because of our ideology. Ordinarily, even the medical doctors, the nurses, and other healthcare professionals, you see them leaving the country on daily basis.
That's right.
And the few that are left are pressured by the work.
Let's
and
talk about
don't have the orientation
the few that
to
are
take
left.
care and absorb the pressure.
According
You find yourself being on the edge.
According to the WHO, we have one doctor to 3,500 patients.
Which is not supposed to be.
Absolutely. 370 doctors to 10,000 Nigerians. Let me run you through the numbers. 370 doctors to 10,000 Nigerians, but specifically one doctor to 3,500 patients. A 2006 inventory showed also that there is 1.03 nurse, I can't call that nurses because to 1,000 Nigerians. So, and remember, we're talking about psychiatric help. We have just about 250 psychiatric doctors all over Nigeria.
For the whole of the country.
For the whole country.
Which is nothing when you equate it to the population of Nigeria.
Absolutely.
Ideally, as a nurse, I am not supposed to take care of more than one patient to be able to give them holistic care. In my facility where I work, occasionally you see just one nurse on duty managing 29, 30, 35 patients. Now tell me, as a layman, how efficient do you think this nurse will be?
Absolutely.
Every patient on that ward deserves to be cared for. Even the patient relations, because by my training, apart from being a nurse, I'm a guardian and I'm a counselor. By the training I have as a counselor, the patient relation equally deserves to be cared for by me.
Right.
So now when you have just one nurse caring for this multitude of patients, most of whom are critically ill, how do you think she will be or he will be at his or her best?
That's a big question. Rotimi, I've told you the numbers. I remember the big one when we had the psychiatrists here in the studio. We talked about probably laminating these 250 doctors, celebrating them specially. I mean, 250, that's about 1 to 1 million Nigerians, estimated. So 250 psychiatrists. We're talking about nurses that need psychological evaluation, need to vent. One nurse to 30 patients. And of course, these patients are critically ill. They want attention and they want it now. Our nurses are stressed. We don't have enough doctors. But someone said we had too many some time ago.
The problem, there is a systemic problem going on, which we need to address and point out. Yeah, these issues are very familiar to me. One of the key areas of my work on sustainable development over the last 20 years or more have been around areas of health financing and human resources for health. I'm on the Africa board of the Africa Platform on Human Resources for Health and co-founded the Abuja 15% health financing campaign chaired by Nobel Prize winner Archbishop Desmond Tutu.
1 minute, Rotimi. Mrs.
And we've worked on these
one minute,
issues.
Rotimi. Mrs. Madonna.
Yes.
Could you please stay in a quiet place? There's noise around you there.
I'm actually at the... Okay, is okay?
Okay, yes, thank you. Rotimi, just go.
She's at the airport.
Oh, okay.
And, we've worked on these issues for about 2 decades. And what we found out essentially is that the governments that fail the most to invest in human resources for health and health financing are the ones that put the health professionals in the most difficult conditions. So you talked about the ratio. What I've found when explaining this to ministers of finance and ministers of education, and let's not forget it's the minister of education that are responsible for training the health professionals, not the health sector.
That's right.
So when explaining it to them, they don't understand this ratio thing. So we translate it into numbers. And we make the point. A country like Nigeria, for its current population of about 200 million, now has less than 40,000 practicing doctors. Nigeria should have about 500,000 practicing doctors. That's the kind of gap that we face. For nurses and midwives, we are short over 1 million nurses and midwives. We've just had, the nurse on the phone explain. She should be caring for one patient. She's caring for 30 or 40. On top of this, in these hospitals, there are no medicines, no equipment, no water, no lights, poor administrative process, so it's not computerized. Yeah. There's just complete mayhem going on there. So, I mean, it's quite, if you go to the countries where there is much better patient safety,
Right.
all these basics have been taken care of. The education sector is better involved in the training of the health of the health workforce. The health sector and the labor sector are better involved in the retention, retraining and retention. And you could see that our Minister of Labor said we have more than enough.
In fact, we have enough to export.
Yes, we have enough to export.
That's it.
I mean, the labor sector is so out of touch that honestly, in any developed country, Ngige would have been sued for criminal negligence. As the Minister of Labor, not to know what the deficit is to the extent of saying we have more than enough,
Ignorantly.
and he has been returned to that same position again to inflict the same on Nigerians for another 4 years. So this big picture is really important. When we say universal health coverage, which is what the whole world is aiming for now, we need to break it down into all the components.
And you made an important point that it starts with education.
Yes.
So we need more of these schools to train
Without
them.
any doubt. And look, it's going to get worse unless the investment is made. And that's why I emphasize on the health financing. We estimated 200 million now. By 2050, will be 400 million or more. So we already have a deficit
Right.
of over 400,000 doctors, over 1 million nurses and midwives. Is that investment being made now? One, to bridge the deficit. Two, to keep up with the population curve. I mean, we are really going to get to the point where patients are going to start rioting in hospitals because there will be so many patients based on our population size suffering from a lot of things that are preventable.
As a matter of
Which
fact.
you don't even have
As-
come
which-
to
yes,
doctors
yes,
in
so-
hospitals.
matter of fact.
We will have many patients suffering from a lot of that are preventable. They will go to the few hospitals available with the ever shrinking number of health workers. In fact, we all see now, sometimes the doctors in government hospitals, the nurses and midwives are not paid their salary.
Right.
They have to go on strike. They are paid half, I mean, the whole thing is insane. We are going to get to that point when patients are actually going to, right? I mean, we've seen it happen in other
Rotimi, please hold the line. We need to go on a break right now. When we return, we'll continue this conversation. In case you are just joining us, you're welcome. It's an interesting conversation. We're looking at medical facilities and patient safety. And we'd like to hear from you when we return as to your own experience when you visited the last time or the previous times you visited, health facilities before in Nigeria. We have joining us on the line, Nurse Madonna Uchendu, the chairman, National Association of Nigerian Nurses and Midwifery in UPT, that's University of Port Harcourt Teaching Hospital. Dr. Tui Mabawado is also here in the studio. He's a medical practitioner and public commentator. Rotimi Sankore, you just heard his word as well. We'll be back in a moment. I'm Sheriff Quadry.
I'm Wemimo Adewuni Season.
Talk, news, and sports after this.
This is the Morning Crossfire on 99.3 Nigeria Info. And if you're wondering what the noise is about, well, Nurse Madonna is at the airport, actually. So, but we need to have this conversation today. We also have Dr. Tui here in the studio. Rotimi Sankore is also here with us. Let's give you some more numbers that would shake you up. According to that's what the numbers do. Now, according to a report done in 2005, a census done, Nigeria has 5 hospital beds to 10,000 Nigerians. The Federal Ministry of Health did a census in 2005 and also showed that Nigeria had a total of 23,640 private and public hospitals put together. That's the total we have. An estimated 5 beds to 10,000 Nigerians. Dr. Tui, a big issue we also always have is, so when we get to the hospitals, there is no bed. Patient safety. Someone who just had an accident is just then laid on the floor, or we find people who have communicable diseases who then have to sit so closely together or just manage these spaces. This is another big challenge.
Really big challenge. First and foremost, if you're considering patient safety, the starting point actually, apart from the education, which I will come back to, is the structure of the hospital. The building must be so friendly. The building must be airy, spacious, well lit. You know, in such a way that a patient that comes for, say, a lump will not pick tuberculosis. It is very, very key. The structure.
It's a design.
It's a special design. Hospital is not just like any other place.
The current designs we have, do they fit this description? Let's talk about maybe the general hospitals and the PHCs.
That's right.
The truth is that the structure of hospital has moved away from what we are seeing now, especially in Nigeria. Because if you want to compare countries that is close to us, maybe we'll look at India or so. But if you now enter an hospital in India and see the structure, how the ward is structured, how the patient flow is arranged, and the whole process, because there's input has to do with the structure, the equipment. Of course, you have to consider safety in equipment. Not that equipment that can be used and cause more problem to the people. Then you have to consider the number of the workers, the quality of training, the education given to them in terms of safety. Do you have safety management team in the hospital to triage and look at what you need to do? Then before you now look at the process itself, how do you move from one point to another? The drug, your pharmacovigilance, because you don't want to give a drug that will give the person Steven Johnson syndrome, any of these complications. And then before you get to the output. But coming back to what Rotimi actually highlighted, the importance of education in even human resources for health cannot be overemphasized. It's a funny kind of thing. If you don't have sufficient secondary school students taking science, and related courses, you can't do the art subject and go and study medicine. It's not possible. So the starting point is actually to recruit sufficient science students to teach this to and then encourage them to take science-based courses in the higher institution and then training. And then even our cadres of training, because even in a place like New York, you still see nurse practitioners, because they have proper process of managing them. But in this part of the world, of course, any guys running chemists want to be called a doctor. They don't even want to be not. So we must be able to look at cadres, because we're in a deep problem in terms of meeting up with the human resources for health, in terms of assuring proper process of treating patients and preventing damages or injury to patients, and then violating the basic Hippocratic Oath.
Dr. Tui, infrastructure-wise, we're not there.
No,
personnel-wise, we're not there. Are we asking for too much in terms of patient safety care?
How can you be asking for too much?
Is it impossible?
How do you develop a country without proper education and healthcare? Basic, too basic. How do you want to? All your theory, highfalutin stuff, everybody's talking, and your budget and all those things will not add up. Okay, because with education and health, people are empowered to maximize their effort. The shocks and fragilities that they might experience are limited. The obstacles and the hurdles they have to cross, are limited. So, interestingly, until we put proper care, proper understanding, not just to the health structure, not just to the patient, to the doctors and health workers as well, but also to the patient. And the best we can do now is to engage the public space to keep educating people
Right.
on what needs to be done. Now, for me, I would tell people that for whenever you get to the hospital, always ask questions. What am I getting treated for?
Have you ever to see hospitals?
Have you tried
I've
that
been
before?
to one hospital.
Have you tried that
Dr.
before,
Toye,
doctor?
this is very.
They'll tell you. They'll
Dr.
tell you.
Toye,
Doctors will
Dr.
tell you.
Toye, they should tell you. I've gone to a hospital where I was given drugs in unlabeled sachet, and I asked, "What drug is this? What is this?" I mean, the nurse just wrote, "Take this 1-1."
And you are speaking as an educated
Yes,
patient.
it says just 1-1, 2-2. I said, yeah. So, but what medicine is this? And it says, well, you don't need to know. What do you mean? I don't need to know what drug I'm going to use?
She should have
I'm
just
sure
said.
she
She should have
told
just said
you
there is no
finally.
labeling device.
I'm sure she
but-
told you finally.
No,
Because
she didn't. I had to go meet the doctor. She told me she couldn't unless she got permission from the doctor, and I had to go to the doctor. I didn't take the drugs home that day. In summary,
Actually, there is
and it was
problem.
a private hospital.
Actually, it is a problem, and you can explain it better. That's not her role.
Right, there should be a pharmacist.
Because again, even
Absolutely.
in a well-organized place, exactly, what you need to do is that even in the process of your treatment, if you're on admission, for instance, at a particular time and day, they will tell you, family come. This is what you have done for this patient.
Right.
This is how it's progressing,
Yeah.
or she is progressing. These are the challenges we may face. So because that,
And these are the options we're looking at.
It's for that reassurance. Okay, we've called the best person because I can tell you my experience with one of my uncles in an hospital, outside Nigeria. We were called in at that interval every day. There's a briefing room. There's a briefing room where the family comes and says, okay, it's your time for briefing now. You have your brief. Somebody sits down there, look at the computer and tell you exactly where you are.
That is when you have
Right.
enough people
That
to
is
work.
quality.
You
Yeah.
don't even have
Yes,
enough
you don't have
people.
Enough
But again-
administrators, enough managers,
Yeah.
good process, good flow, input, output.
Yes. If we are swear, we can still get something done.
Dr. Toye,
Because-
please, a big challenge also with patient safety is data gathering. So, registration. If I go to a hospital and I'm treated for A, if I move to another place or I use another hospital, I start from scratch. In fact, many times if I return to the same hospital, if someone can't find my file, that's the end of it. I mean, you go around and your file, I'm sure many Nigerians have files in about 5 hospitals across the country. So there is no flow that shows a chart of what you've been treated for over the years.
Really, what can solve that is the electronic health medical record system.
Right, right.
Now, I think to a large extent we should be developing that. We have been developing that electronic health medical record system whereby it's possible to transfer your information from one place to another on your request. And then what also happens is that a lot of tests that you have to do, you must have your copy. It's not my business. If this is your condition, I'll give you your copy.
Right.
What I used for me, those activities, what I used to tell patients is that, listen, yes, you are paying me for knowing that you have to use Panadol, and I can charge anything for that. Okay, but I'm not going to hide any drug because you know that I'm giving you Panadol. I'll just also warn you that if you don't have this kind of sickness and use this drug, whatever is your challenge, face it.
Right.
So that point of clear information becomes important if we have to get, and it comes with practice, it comes with education, it comes with somebody having, like I said, I agree there's quite a lot of stress practicing healthcare in everything in Nigeria.
Right.
But again, we must be able to look at triaging, because if we do proper triaging, we can resolve this thing. A lot of people can be employed, they may not actually be, they may need basic treatment. In terms of educating patients, this is what the doctor says. The doctor can easily transfer that from one point to another. This is what the doctor says. This is what you need to do. If you need further information, please, at this point in time, call this person.
Rotimi, let me hold you a bit, Dr. Tui. We have a patient bill of rights, actually. So, in terms of policies, I think we have some stuff on paper. We also have the Nigeria National Health Policy 2016. We also have a second National Strategic Health Development Plan that spans 2018 to 2022. We had one in 1988, we had in 2004. So we have these policies, and the Minister of Health said, then that, we're going to follow out this plan. We're going to, in fact, eliminate malaria, death caused by malaria in 2020. 2020 is just next year, by the way, and so on. So we have a lot of great things on paper, but Is this enough?
Okay. Can we please not call those things policies or plans?
That's what they're called. That's what they're called.
No.
It is actually called Nigeria's National Health Policy. So I wasn't the one who called
I
it.
know. I'm not blaming you. Those things are papers.
They're policy documents.
Yes. And as I always explain, the reason why is this. So I've been involved in drawing up global policy on development issues. A proper policy paper, it has many columns. The first one says, it breaks it down paragraph by paragraph. This is what this paragraph aims to remedy through XYZ way. The next column will cost it. This is how much it will cost. After that, it will say, this is who is responsible for implementing it. After that, it will say, this is how much it has to be costed. And this is when we expect to achieve it. Then it is sequenced in a way that you understand that if you don't achieve A, you can't achieve B.
Right.
If you don't achieve B, you can't achieve
And the
C.
timelines following that
And the timelines are
order.
clear. When you see policy paper in any underdeveloped country like Nigeria and they put it up, it's just, it's just something that somebody wrote, just several paragraphs that says that this is the plan. And at the end of that plan time, it can be 2020, it can be 2025. You look at that paper again and you are, so how much was this thing to have cost? Who is to be held responsible at each point if it doesn't work? And so on
Where
and
is
so
the
forth.
funding for it coming from?
So when people, it's important to explain this, because when people say we have policy, we have more than enough policy, the problem is implementing. Actually, we don't have clear policy. That's why there is multiple policy failure on multiple grounds. People go to hospital for things that could have been prevented. There is a cholera outbreak. People are chasing the Minister of Health about. Okay, he will help to cure. How about the Minister for Water?
Right.
Or the guy in charge of sanitation or environment. Nobody queries them and says, excuse me.
Because they contribute to the health burden.
Yes, because it's their own policy failure that led to the other matter. So this is why I say that there is no, and then there is something called joined up government, or in policy terms, multi-sectorial responsibility. The ministries should be working in clusters. Right. All the ministries that their work affects each other should form a cluster, not just at federal level. In a federation like Nigeria that has 3 tiers of government, I'm always baffled. For instance, when there is a security problem, and we know that unemployment or poor education is one of the causes, they start calling meeting of security chief. Nobody says, excuse me, Minister of Education, why don't you call a meeting of the commissioners of education in the area and address the problem? It is insane. In this country, we should be having such quarterly meetings. Right. The minister meets with the commissioners at all levels, quarterly. Then those in clusters then meet together to say, well, this is the challenge we have. It is you, A, B, C, D, that can act and impact on that for me. So it's like the Minister of Youth, Sunday Dare, who ordinarily has the intellectual capacity to move that ministry forward. He's not in charge of education.
Right.
He's not in charge of vocational training.
Right.
And these are the things that you need to empower the youth. We can give a million examples like this. So in terms of health, so we don't manufacture medicines in Nigeria. We don't manufacture devices. We make Panadol and all the.
We do some. Because I know quite a number.
Yes. When you are talking of serious things, we don't. Medical devices and we don't. Now, why hasn't the relevant ministers been called into this conversation? Why? That's a big question. Yes, we have people in charge of manufacturing, science, technology. Yeah. They have not been called into this conversation. Education has not been called. Why don't we have enough doctors or lab technologists and so forth?
That's a big question. again, I just wonder. We have all these people here, the ministers. Question is, don't they know what to do?
Actually, many of them don't.
And why are they there if they
Many
don't
of them
know?
don't. It's patronage. They were appointed for political purposes.
Not switch and
the
do.
ones,
Not
the
switch
ones
and
that
do.
know are outnumbered.
I am aware you will soon go on board right now, but let's quickly ask you this. You mentioned earlier about the shortages in the health sector. You mentioned shortage of personnel in terms of nurses and doctors. And okay, I can see that you're about to board. So very quickly.
No, go ahead. It's not my slide.
Okay, so how can we address these shortages? How? Because if the pressure is on the nurses, if the bigger pressure is even on the doctors, that means, patient safety is just in the hands of God. Not that the doctors and nurses won't do enough, but how can we address this really?
Thank you so very much. This particular issue really requires urgent attention by our government and our Minister of Health. If the healthcare facilities, if the health sector is properly taken care of, good remuneration, I don't think Nigerians would for any reason want to leave the shores of this country to go and seek for greener pastures elsewhere. That is actually why we are short. It's not that we don't have trained nurses or doctors in this country, but the quest for greener pastures outside the shores of Africa has, to a large extent, contributed to the shortage of manpower in our facilities. Okay, take for instance, a medical doctor qualifies, a nurse qualifies, the pharmacist, and they are not getting this employment as and when due. And people somewhere, in fact, let me tell you something that will baffle you. About 2 years ago, some people were employed in my facility. And by the time, through this godfatherism issue, by the time they came in and reported in the nursing department, we found out that 2 of them were not trained.
Oh, wow.
Probably they bought certificates.
Wow.
Assuming the person there was not able to identify them. You think you have a professional working with you, and the person now endangers the patient's life because he or she does not have what it takes to render care.
It is a good point to ask you about private hospitals that use what is term
Yes, because
auxiliary
you raise that
nurses.
issue.
So there are hospitals. I'm saying in some private
nurses, it's like a glorified name.
In some private hospitals,
they
in these hospitals, some of them are nurses in training. But they have uniforms. I've seen some private hospitals that use them, and they say they learn on the job. And my question is a hospital the best place to train a nurse on the job? Practicing with my life?
No, sorry. Let's get something right. Any person being trained or taught by a doctor or a nurse in a private setting cannot be called a nurse.
Absolutely.
That person is a quack. Short and simple.
Great.
And, the scenario you gave, the experience you had that they gave you drugs to take one in the morning, take one morning, take one at night. No professional nurse will do that to you. I, for instance, react to drugs. I react to certain drugs. And you cannot give me a drug that I don't know the name, and you tell me take this and take that.
Yeah.
You have to tell me what I'm taking. Because it could be one of those I react to. So those people in the private clinic that are training them, in fact, they are supposed to be arrested, both the owner of the facility, the trainers, and the trainees.
I second that motion.
God bless you, my sister. Because they are helping to kill people. Most of the deaths in the private hospitals and all that are actually deaths that could have been prevented or avoided.
The people to initiate this arrest don't use the government hospital.
That's the sad part.
They go abroad to treat earache and the other things.
It's a good time to get to the phone. The phone lines have been buzzing.
The truth of the matter is, if these government functionaries that go abroad, if they are in emergency situation and they are exposed to access care in these places manned by quacks, what happens to them?
Well, they don't.
Will they be alive to travel?
And they don't even
They will not be alive to travel
in
to
developed
get to their
country.
destination.
All the senior politicians, the royal family, and others, they use the general hospital.
Do you think we need to make?
They go to the general
Even
hospital.
our president
The prime
is supposed
minister
to
is
use the
sick. They go
facilities
to
in
the
Nigeria.
general hospital.
Should we make a law to make it compulsory for everyone?
Should it be mandatory?
Yes.
If you're a public office
Public
holder,
officer,
you have to use the public facility.
Making the law is not the problem. It's implementation of the law. That is where we have so many laws that have been enacted, but they are not implemented.
Absolutely. All right, let's give you the phone numbers, Nigeria, if you'd like to join us. Here we go.
Call us on 01-277-0993, 01-277-1993, 01-277-2993, and 01-277-3993. This is Nigeria Info. We are listening.
This is Nigeria Info. We are listening, and we're talking about medical facilities and patient safety. We have lots of messages from Facebook. I guess we'll start from there. Raphael Adegoke from Lekki says, the state of our public hospitals in Nigeria is so appalling. Go to Luth and see what's going on there. They treat patients of malaria and they don't have nets on their own windows. Wow. Now this one.
What an
He
irony.
said there was
That's
a
what
day.
I'm saying. No medicine, no water, no light, no bed.
So
no,
you're admitting someone for malaria, but there's no mosquito nets. It says there was a day I went to visit a sick friend. Can you imagine? We saw rats running around in the hospital ward. The government really needs to do more in making our hospitals function properly.
Let's speak with Ferdinand. Ferdinand is here. Hello, Ferdinand.
Yeah, good morning, Wemimo.
Good morning.
Good morning, everybody. Doctor and the studio and Rotimi.
Morning.
Good morning.
Yeah, there's a lot to talk about, but let me just make it simple. Let's start with the doctors you have in the studio. Doctor, please, why is it that we don't have a good medical structure in Nigeria? Why is it that we have shortage of doctors and all the rest? Having worked with the state government, as you have said, what was your impact and how have you pressured the government to do the right thing concerning our health danger?
That's a little. You will have to listen for about an hour if you want to understand what I have done extensively. You understand? But again, the challenge
And
is
let's
this.
highlight that he's a private practitioner.
Yeah, I had worked with government for 21 years.
Yeah, great.
And the challenge is that, first of all, encourage your child to do science. That's the starting point. Do the investment to make your child study science so that they can actually become one of the health workers or study engineering. If you fail at that point, then there's a problem. Like we said, education is key. It's a funnel kind of thing. If you don't have people doing science, if you don't encourage science, you cannot study medicine. Then secondly, university is also about education.
Right.
Let's also be able to encourage the government to incentivize, some of these people, studying this course. They probably will have enough. If you have sufficient doctor like Cuba had, then I'm sure
We're moving closer. We have someone on the line
anonymous.
chooses to be anonymous from Surulere. Good morning.
Good morning.
Good morning.
Good morning.
Good morning. So, first and foremost, thank you so much for your show. It's been very enlightening.
Thank you.
Okay, so I'm a pharmacist myself, and I have to say that there's one particular issue that hasn't really been covered in this conversation, and that's the issue of cost. Now, of course, if you look at the current status of Nigerian hospitals, of course, they're nowhere near international standards. But to actually bring them closer to international standards, there's no way you're not going to have a cost implication. For instance, you're talking about a single person being treated by a single nurse. So you can imagine that person is going to have to pay out of pocket for whatever treatment that they're having. The nurse, of course, has to be well remunerated for the number of patients that she's actually seeing, or additional number of nurses have to be employed to ensure that each patient actually has enough nurses to take care of them and also enough doctors to take care of them. So how exactly do you propose, going forward that we should have this number of nurses or this number of doctors and at the same time a very low cost of healthcare? Do you think that is actually feasible?
Right.
It is.
Thank you.
If the right investment is made over the right period.
We have Bukola from Ikorodu. Bukola, good morning.
Good morning.
Good morning, Bukola.
Thanks so much for this topic
Thank you.
morning. Yes, I'm a nurse by profession, and I work with government hospital.
How many patients do you treat in a day?
I work in the theater.
Oh, okay. All right.
So, yeah, and they are animals. It depends on the emergency that they bring in. Like this morning, I will be having a list of 9 on my list.
Wow.
Yeah, to be operated upon.
Your average shift spans for how many hours?
Thank you, Sheriff.
It's between 8 and 4 p.m.
Okay.
9 patients.
Is there any overtime? Do you usually do overtime?
Yes, overtime. If it can last till 6 until you are through. Because if the other extension has emergency, another person will go there. So, and you have to hold on for the person on call before you leave.
Right, absolutely.
And when you are talking about nurses' attitude, it is because of the enormous work. Like Mrs. Madonna has rightly said, she has nailed it that we have short staff. Both doctors, nurses, and even the paramedics that we work with, we are short staff. So we are begging the government, let them employ. We have people outside looking for jobs.
Right. Thank you so much for calling us.
Thank you, Bukola. Thank you. Chukwebuka is here from Shemulu. Chukwebuka, good morning to you.
Yeah, good morning, Wemimo.
Morning.
And Sharif and the guest in the studio.
Morning.
My name is Chukwebuka, calling from Shemulu.
You're welcome.
Thanks for this topic, like every other caller just said. My friends abroad will say, pray that you don't have a major sickness or illness as an average Nigerian.
I know, right?
It makes me sad. It makes me feel very, very sad. You see, the fact remains that this brain drain will continue until the right thing is done. The government, everybody, they have what it takes to turn our hospitals, our clinics into a world class. Because they still fly abroad, when they have issues or health issues, they will never do anything about it. It's just like education. When they said government officials should stop their children from schooling abroad, it never happened. I heard your guest when he said implementation is the problem. They cannot implement these things. If it's implemented, and then I can assure you, things will be done properly well.
All right, you can
let them implement it. Thank you very much.
Thank you so much.
That we have had world class in Nigeria before.
Now.
Yes, at least me, I saw with my eye.
Good morning.
Hello, good morning.
Hello, good morning.
Yes,
please stay away from your radio. Tell us your name.
My name is Biola.
All right,
Biola, please stay away from your radio quickly.
Oh, I'm trying. Sorry.
Okay. You ready?
Oh, Biola is gone. Biola, you can try and call us back if you can. All right, let's take another call. Hello, good morning to you.
Good morning.
Yes, good morning.
My name is Michael. I'm calling from Ekwe.
Welcome, Michael.
I so much love your topic this morning. I want to talk about the general hospital stuff. If our politicians can renovate at least to make the general hospital more standard, I'd not any reason why some politicians will be going outside for treatment. Even the money that's spent outside there, they can even use it to invest in the general hospital we have in this country. And even when you go to some general hospital, for you to see a doctor is problem on its own. You have to wait. In fact, you even get tired. You even decide to be going home because
you go with your sickness.
Is not. Hello?
Go ahead.
Go home to go and die.
And the standard of general hospital in Nigeria is, in fact, is unbearable.
All right, then. Thank you so much for calling.
I'm scrolling through the National Health Policy document, and sincerely, it's just a lot of text going on. Text upon text upon text.
We will do
pages. Yes, we will do. We ensure we will ensure. Oh wow, this is something else. Well, we must go now. Thank you all for joining the Morning Crossfire today. The conversation continues on our social media handles at Nigeria Info FM. On Facebook, we had a comment here from Iwodi Ahmed Mike, who says, God will save us from the hands of HMOs. Says he went to a hospital to get treated for an illness, only to discover that the HMO instructed the hospital not to give treatment above 2,500 naira.
Yeah, that happens.
That one is a different.
That depends on the package.
There's also a message here from an anonymous on Facebook, and she says, I was pregnant and gave birth months ago, and how I was treated at the general hospital was too bad, utmost negligence and levity. It led to the death of my baby. Wish I could give you more info if she.
I am so sorry about that, Abisola. So sorry to hear that.
It is key that for all of us, we need to first of all do a health audit. We need to do a health audit to understand the gaps, and then secondly, we need to push the primary health care. Because again, talking about tertiary is too expensive. Let us put the primary health care.
Let's bring it down. Let's bring it home.
We are talking about Cuba. I mean, that's the basis of.
Let's continue this conversation outside of here. We have to go now. Thank you all for joining. Also, big thanks to Nurse Madonna Wichendu, who's the Chief Nursing Officer, National Association of Nigeria Nurses and Midwifery, who joined us over the phone, and also to Dr. Tuyi Mebawadu. Thank you, Dr. Tuyi.
My pleasure.
Rotimi Sankore, thank you. Nigeria, let's do this again tomorrow. Tomorrow we'll be x-raying all those journalists who have been detained in the past months. And questions about the freedom of press and the role of the government in ensuring that Nigerians really can speak freely. Join us tomorrow for more on that. I'm Wemimo Adewuni.
I'm Sheriff Quadry.
Big thanks to Tosin Akirinde, Zainab Yakin, and also Yvonne Ohaifo for assisting. We'll see you tomorrow.